Hello. All right. So, a very good evening, everyone. Am I audible and visible to all of you? Just 1 minute, guys. 1 minute. Okay. Right. So, yes, thank you very much. And yeah, so the PDF of today's session, that is the respiratory system and as well as the neurology, I have sent it on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, right? So you can download this particular PDF on my Telegram channel. And let me start the session. Okay. So yeah, Mukherjee, I will do all the topics. Don't worry. I will do all the topics. So the other topics that will be due will be cardiology, endocrinology, and as well as nephrology. So these three topics will be due. I'll be doing those three topics also together. So don't worry about that. But for today, I'll be doing the respiratory system and as well as the neurology. Okay, right. So let us try to cover as many number of questions in the topic of the respiratory system first. So now, in the first important thing in the respiratory system is the discussion on the pulmonary function test. The discussion on the pulmonary function test. Okay, so please go through this question and answer this question. Yesterday's session was awesome. Thank you, Ritiraj. Thank you very much. Yeah, so I'll try my best. Even today's session also will be the same like yesterday's, and I'll ensure that the topics whichever I'm covering, you'll be having the great coverage in your the upcoming FMG exam, right? So in the yesterday's also session also, I've tried to cover all the topics, all the subtopics of the connective tissue disorders and as well as the hepatology. Right? Yes. So what is the answer? A coal mine worker develops progressively worsening breathlessness and cough with expectoration. Spirometry values are FEV1 1.4 liters per minute and the FVC 2.8 liters per minute. What would be the cause? No, only we have correct answer from Ritraj Sahu. So the answer is the COPD. The answer is COPD. Okay. Why? Why the answer is COPD? Let me try to explain to you. Right. So 1 second. Right. So if you take the FEV1, FEV1 is right. So FEV1 is 1.4 liters. And if you take the FVC, that will be 2.8 liters. That will be 2.8 liters. Okay. Now, what is the ratio that you will get? The ratio that you will get is 0.5. The ratio that you will get is 0.5. Okay. So now, what is the normal FEV1 by FVC? Normal, right? Normal FEV1 by FVC will be 0.7, right? And here, how much is the value of FEV1 by FVC? It is less than 0.7. right? It is less than 0.7. Now, because it is less than point, so in which type of disorders you will have the FEV1 by FVC less than 0.7? You will have this in case of the obstructive lung diseases, right? And among the options which has been given to you, which one is your obstructive lung disease? Your COPD is an obstructive lung disease, whereas silicosis is a restrictive lung disease. Hypersensitivity pneumonitis is also a restrictive lung disease, and idiopathic pulmonary fibrosis is also a restrictive lung disease. And in restrictive lung diseases, what will be your FEV1 by FVC? In restrictive lung diseases, the FEV1 by FVC will be more than or equal to 0.7. Will be more than or equal to 0.7. Okay. And here the value is like 0.5, which is less than 0.7. That is the reason why it is suggestive of obstructive lung disease. And the example of the obstructive lung disease here is COPD. Right. Now, what is that I'll be discussing in detail now? Right. The topic in detail that I'll be discussing is about the pulmonary function test. Now, what exactly is the purpose of the pulmonary function test, right? So the purpose of the pulmonary function test, it is mainly to differentiate the obstructive lung diseases from the restrictive lung diseases. That is the important purpose of the pulmonary function test, right? And in this entire pulmonary function test, what is very important maneuver, which is crucial for the diagnosis? What is very important maneuver which is crucial for the diagnosis is the forced expiratory maneuvers are very much crucial for the diagnosis, right? Now, what are the various volumes and capacities that you have? So you have the capacities like total lung capacity, vital capacity, inspiratory capacity, and residual volume. But one quick question for all of you. Now, out of all these volumes, please tell me, spirometry or spirometer cannot measure which volumes and capacities? Yes, spirometer cannot measure which volumes and which capacities out of all these volumes and capacities. Anyone? Out of all these volumes and capacities, spirometer will not measure which volumes and capacities. Right. So, very good, Shainavas. So, the spirometer, it cannot measure the residual volume. Spirometer cannot measure the residual volume, right? And spirometer cannot measure the functional residual capacity, right? Then spirometer cannot measure the total lung capacity. So these are the volumes and capacities that cannot be measured by the spirometer. Now, the quick question is, now these residual volume, functional residual capacity, and total lung capacity, they are measured by which instrument? Anyone? Total lung capacity, residual volume, and functional residual capacity. They are measured by which particular instrument or which equipment? Anyone, please? So, the methodology by which we measure the total lung capacity, residual volume, and functional residual capacity is, that is by helium dilution method, right? Then, nitrogen washout method, right? Then, body plethysmography, right? Body plethysmography. So these are the various methods by which the total lung capacity, residual volume, and functional residual capacity can be measured. Out of all these, which is considered as the best method, the body plethysmography is considered as the best method in estimating the total lung capacity, residual volume, and as well as the functional residual capacity, right? Now, they may ask you about the values, out of which, please remember, the total lung capacity is around 6 liters and tidal volume will be around 0.5 liters. Then expirator reservoir volume is 1 liter, residual volume 1.2 liter, inspirator reservoir volume 3.3 liters. But out of all these, what is very important that you have to remember from the exam point of view is this FEV1 by FVC value. That is the one which you have to remember first. Okay. Now out of all these, so what was the basic function of your pulmonary function test? That is mainly to differentiate obstructive lung diseases from restrictive lung diseases. So the quick point that you have to definitely remember in your exam is what? FEV1 by FVC is decreased in obstructive lung disease, whereas the FEV1 by FVC, it will remain normal or increased in case of the restrictive lung diseases, right? Then followed by that, we have the DLCO. DLCO is nothing but diffusion capacity of the lung for carbon monoxide. So if you take the diffusion capacity of the lung for carbon monoxide, that will be decreased in conditions like interstitial lung disease, which is a form of restrictive lung disease, and it is also decreased in case of emphysema, which is a form of the obstructive lung disease. Whereas the DLCO will remain in extrinsic type of restrictive lung diseases. What are the examples of extrinsic type of restrictive lung diseases? The extrinsic type of restrictive lung diseases that includes the obesity, kyphoscoliosis, right? Then ankylosing spondylitis, myasthenia gravis, phrenic nerve injury, diaphragmatic palsy, muscular dystrophies. These are all the extrinsic type of restrictive lung diseases, right? Then next important parameter that you need to remember is the peak expiratory flow rate. So peak expiratory flow rate, it is reduced in patients with the obstructive lung disease, and that is very, very important. And another parameter that you need to remember is the forced mid expiratory flow rate. So forced mid expiratory flow rate, please remember, it is a measure of the smaller airway disease. It is a measure of the smaller airway disease. Okay. Now, what are the examples of the smaller airway disease? COPD, it's a smaller airway disease. So, your forced mid expiratory flow rate, which is a measure of the smaller airway disease, the forced mid expiratory flow rate is reduced in patients with the obstructive lung diseases, right? Now, I have just given you the flow volume curves, how it will be. How will be the flow volume curves? Now, if you take the flow volume curves, I'll just come back to this flow volume curves in the last, right? Because I need to show the images for that. But before that, I just want to tell you what will be the various parameters abnormal in patients with the obstructive lung diseases. Now, in case of obstructive lung diseases, what are the examples? The examples include, just please remember, A, 2B and 2C. A stands for asthma, B is your bronchitis, another B is bronchiectasis, C is cystic fibrosis, another C is COPD. These are the etiologies that will be causing obstructive lung diseases, right? Now, if you take the pulmonary function test, one of the very important pulmonary function tests is your FEV1 by FVC. What will happen to your FEV1 by FVC? That will be decreased in patients with obstructive lung disease. And remember, in case of obstructive lung diseases, right, everything will be decreased. But the parameters that will be increased will be these, right? That is total lung capacity, residual volume, functional residual capacity. They are increased in patients with the obstructive lung diseases, whereas FEV1 by FVC and as well as peak expiratory flow rate, it is decreased in patients with the obstructive lung diseases, right? So these are the features that you will have in OLD. Then you take in case of the RLD in restrictive lung diseases. What exactly is the problem in restrictive lung disease? There will be restriction to the expansion of the lung. And this restrictive lung diseases, we have two types. One is parenchymal and the other one is the extraparenchymal. Now, what is these parenchymal causes? That includes sarcoidosis, pneumoconiosis, idiopathic pulmonary fibrosis, drug or radiation-induced interstitial lung disease. Then what are the extraparenchymal causes like kyphoscoliosis and obesity? But what is very important in the pulmonary function test of the restrictive lung diseases? In restrictive lung diseases, the FEV1 by FVC, it will remain normal or it is increased in patients with the restrictive lung diseases. And in case of restrictive lung diseases, almost all the volumes and capacities, they are being decreased. Right? Total lung capacity, residual volume, functional residual capacity, it is decreased, right? And in these patients, the DLCO, it is decreased in case of the intrinsic type of restrictive lung disease, and it will remain normal in case of the extrinsic type of restrictive lung diseases, okay? So this is about the discussion related to the OLD and as well as the RLD, which is very, very important part of the discussion, right? Now, I'll just show you the flow volume curves. Right, just give me 1 minute. I'll just show you the flow volume curves. Right. So if you take this flow volume curves, see, this is the normal flow volume curve. Okay. Flow volume curves are those which are asked very frequently in your exams. So this is a normal flow volume curve. So in this normal flow volume curve, you can just make out the part of the curve which is on the lower side will be inspiration, and the part of the curve which is present above will be the expiration. Now, what will happen to these curves in case of the obstructive lung disease? So in patients with the obstructive lung diseases, you can see this is how the pattern of the flow volume curve in case of the obstructive lung diseases. So you can just see that the expiratory component, whichever is there. So this is the expiratory component. So the expiratory component, it is reduced. Expiratory component is being reduced. That is what you will observe in case of the obstructive lung disease. All right. Then, whereas you take in case of the patients with the retrosternal goiter. In patients with retrosternal goiter, right, the inspiratory component will be reduced, right? Only the inspiratory component will be reduced, whereas the expiration component will remain normal. That is in a patient with retrosternal goiter. Whereas in those individuals, yeah, this is variable, yeah. Whereas in those individuals who are having variable intrathoracic obstruction, those individuals where there is variable intrathoracic obstruction in the form of laryngeal tumor, in these patients, the expiratory component will be reduced, but the inspiratory component will remain normal. Right, the inspiratory component will remain normal. Only expiratory component will be reduced in case of the laryngeal tumors. Okay, whereas in patients with the tracheal stenosis, wherever there is tracheal stenosis, both the components are reduced. Inspiratory component is reduced, and as well as the expiratory component is also being reduced in patients with the tracheal stenosis, and that is considered as a fixed obstruction. That is considered as a fixed obstruction. Okay, so that is about the story related to the flow volume curves. Right, now I will just go back to the discussion. Okay, so yes, now you see this. So in case of the fixed airway obstruction, what is your fixed central airway obstruction? The fixed central airway obstruction is nothing but the tracheal stenosis, where you will have flat the inspiratory and as well as the expiratory curve. Whereas you take in case of the variable extrathoracic obstruction, you will have the flat inspiratory curve. What is that flat extrathoracic obstruction? That is retrosternal goiter. Whereas variable intrathoracic obstruction, what is that? That is in case of laryngeal tumor. You will have the flattening in the expiratory curve only, right? So this you have to definitely remember for your exam. This you have to definitely remember for your exam. Okay. Now, that was about the discussion related to pulmonary function test. Now, next topic for the discussion will be ARDS. Next topic for the discussion will be ARDS. Yes, please answer this question. Match the following conditions with their respective types of respiratory failure. Yes, right. Very good, Rishi Gautam. The answer is C. So in case of the ARDS, it is type 1 respiratory failure, right? Whereas in case of the status asthmaticus, so in status asthmaticus, what is the type of respiratory failure that you will have in status asthmaticus? That will be type 2 respiratory failure. And which is considered as perioperative respiratory failure? That is type 3. And what is that you will observe in case of the cardiogenic shock? That is your type 4 respiratory failure. Now, our area of discussion is what? That is ARDS. Okay, our area of discussion is the ARDS. So let me try to discuss ARDS in detail. Now, what exactly is the problem in patients with the ARDS? So in patients with ARDS, there is diffuse bilateral pulmonary parenchymal disease. Diffuse bilateral pulmonary parenchymal disease, and the type of pulmonary edema that you will have is non-cardiogenic pulmonary edema. And these patients with ARDS, what is their presentation? The presentation, it is in the form of severe respiratory distress causing hypoxemia. And these patients, they will be requiring mechanical ventilator and they have to be placed in the ICU. Now, what are the various synonyms for the ARDS? Synonyms for this ARDS is shock lung, diffuse alveolar damage, acute alveolar injury, or acute lung injury. Now, coming to the etiology of ARDS, out of the various etiologies that will be causing ARDS, the most common direct lung injury causing ARDS will be pneumonia. Most common indirect lung injury causing ARDS will be sepsis. And overall, what is the most common cause? The overall most common cause is also the sepsis. The remaining etiologies and all you can go through. Now, this particular ARDS, it occurs mainly in three phases. What are those three phases? Exudative phase, fibroproliferative phase, and fibrotic phase. So, when the individual is being treated in exudative phase and fibroproliferative phase, then the ARDS can be reversed. But if you try to intervene the patient in fibrotic phase, if you try to intervene the patients in fibrotic phase, then it will be of no use, right? The prognosis will be very bad. And in exudative phase, what exactly is the problem? There will be protein-rich edema that will be there within the alveolus. And there is damage to the pneumocytes. There is damage to the pneumocytes as well, both your type 1 and type 2 pneumocytes, right? And in exudative phase, you will have the formation of the hyaline membrane within the alveoli. Whereas in the fibroproliferative phase, you have the influx of the fibroblast and proliferation of the fibroblast. Whereas in fibrotic phase, you have the fibrosis of the pulmonary parenchyma. So these are the three important phases in ARDS: exudative, fibrotic, and fibroproliferative and fibrotic phase. Then, what is the criteria for the ARDS? The criteria for the ARDS will be the Berlin's criteria, in which you have four important manifestations. That is A, R, D, and S, right? So what is this A, R, D, S? The word A stands for the disorder has acute in onset. Okay, acute in onset. Within 1 week of the clinical insult, the individual will be developing respiratory distress. R, the word R stands for reduced PaO2 by FiO2. The word R stands for reduced PaO2 by FiO2. Okay, so that will be your R. Then you take D. D stands for diffuse bilateral pulmonary parenchymal disease, right? Diffuse bilateral pulmonary parenchymal disease. Okay, on the chest X-ray. The word S stands for Swan-Ganz catheter, which shows normal pulmonary capillary wedge pressure. The word S stands for Swan-Ganz catheter that shows the normal pulmonary capillary wedge pressure, and the pulmonary capillary wedge pressure that will be less than 18 millimeters of mercury. So that is your diagnostic criteria. That is nothing but your Berlin's criteria, right? That is nothing but your Berlin's criteria. Okay. Then how do you assess the severity of the ARDS? That is mainly based on PaO2 by FiO2. So if PaO2 by FiO2, if it is 200 to 300, that is considered as mild ARDS. If the PaO2 by FiO2 is considered as, if it is 100 to 200, it is moderate ARDS. And if PaO2 by FiO2, if it is less than 100, it is considered as severe ARDS. Okay, so mild, moderate, and severe form of the ARDS, right? Now, what are the clinical features that you will have in these patients? So they will be having respiratory distress. Because of reduced surfactant, there will be alveolar collapse in these patients. And because of the fibrous tissue formation within the lung is considered as the stiff lung, where there will be reduced compliance. And these patients, they'll have diminished tidal volume. So whenever you do a chest X-ray, what is that you will notice in the chest X-ray? You will have diffuse bilateral pulmonary edema. Then how is that you will be able to differentiate from the cardiogenic pulmonary edema? Because ARDS is non-cardiogenic, right? So how will you be able to differentiate is, you take the cardiothoracic ratio. There will be normal cardiothoracic ratio and there will be normal postophrenic angle. Okay, normal cardiothoracic ratio and normal postophrenic angle. Whereas in cardiogenic pulmonary edema, it is exactly the reverse. There will be increased cardiothoracic ratio, there will be batwing pulmonary edema, and there will be blunting of the postophrenic angle. That is what you will observe in the chest X-ray. What are the complications that you will come across in patients with ARDS? Because these patients have to be placed on mechanical ventilator for their support. So they will develop ventilator-associated pneumonia. Commonly, the organisms are Pseudomonas and Klebsiella. And they are present in ICU for longer duration of time. So they can develop psychosis, DVT, gastrointestinal bleed, and as well as the catheter-related infections. Then how do you manage these patients? So management of these patients is by these patients have to be placed on mechanical ventilator. And whenever the individual is placed on mechanical ventilator, the tidal volume that you will be maintaining is 6 ml per kg, right? And you need to provide adequate PEEP, and usually the PEEP will be around 10 centimeters of water, which will be giving positive pressure to the alveoli. And what should be the position of these individuals? Prone position. So in prone position, that will cause, the residual volumes that will get preserved, right? In case of making the individual to lie down in prone position. And you should not give excessive fluids. Already there is like pulmonary edema. So you should limit the fluid. That will prevent the pulmonary overload. And if at all, if there is death in these patients, what would be the cause of death in these patients? The cause of death in these patients is sepsis. Okay, so this is about the ARDS. So let me just revise ARDS in 1 minute. Another name for ARDS: shock lung, diffuse alveolar damage, acute alveolar injury, acute lung injury. Most common cause, sepsis. Most common direct lung injury causing ARDS, pneumonia. 3 phases: exudative phase, fibroproliferative phase, fibrotic phase. So fibrotic phase is that which will occur after 21 days, where the prognosis will be very bad. The aim of the criteria, Berlin's criteria, right? What is there in that criteria? ARDS. And how will you assess the severity? That is reduced PaO2 by FiO2. Mild, 200 to 300. Moderate, 100 to 200. Severe, less than 100. Right? The clinical features will be severe onset respiratory distress. What does the chest X-ray show? Diffuse bilateral pulmonary infiltrates, where there will be normal cardiothoracic ratio, normal costophrenic angles. Complications will be ICU-related complications like psychosis and ventilator-associated complications like pneumonia. And in the treatment, these patients will be placed on mechanical ventilator and low tidal volume has to be given. An adequate PEEP to open the alveoli. And the cause of death, sepsis. That is about the ARDS. Chalo. Done. The next topic is pleural effusion. Yeah. Which of the following is not a part of the criteria used to distinguish between the exudative and transudative type of pleural effusion? Yes. So the next topic for the discussion will be pleural effusion. Very good, Rishi Gautam. So the pleural fluid LDH, less than 2/3 of the blood glucose, that will not help you to distinguish between exudative and transudative. Whereas these 3 criteria, they are the features of exudative type of pleural effusion. They are the features of the exudative type of the pleural effusion, right? Now, out of these 3 features, how many should be there to consider the Light's criteria to be positive? Okay, so if you take the Light's criteria, at least 1 out of 3 should be positive. In Light's criteria, at least 1 out of 3 should be positive to consider the Light's criteria to be positive. And that is what is considered as exudative type of pleural effusion, right? Right. So now let us start with the discussion related to pleural effusion. Right. So all of you are ready for discussion related to pleural effusion? Chalo, we'll start. Now, first and foremost, how much is the normal pleural fluid quantity? Normal pleural fluid quantity is around 5 to 15 ml. 5 to 15 ml is the normal pleural fluid quantity, right? Then when will you consider that the patient is having the pleural effusion? If the quantity of the pleural fluid in the pleural space, if it is more than 20 to 30 ml, then we consider it as pleural effusion. When you do a CT scan, CT chest can detect as small as 10 ml of the fluid also. CT chest can detect as small as 10 ml of the fluid also, right? Whereas you take the clinical detection. Clinical detection is possible when the quantity of the fluid is around 300 ml in the pleural space. Chest X-ray can detect the pleural effusion when the quantity of the fluid is more than 100 ml in the lateral view. Chest X-ray can detect the pleural effusion if the quantity of the fluid, if it is more than 200 ml in the frontal view. That is a definition, or that is a detection. And if you take the normal features of the pleural fluid, normal pH, if you see, that is slightly alkaline, that is 7.6 to 7.64, right? The proteins will be around 1 to 2 grams per deciliter. The LDH will be less than 50% of the plasma. The glucose quantity will be similar to that of the plasma, and the WBC count will be less than 1000 per cubic millimeter. So this is the normal pleural fluid. And how do you classify this pleural effusion? Transudate and exudate. So transudate is nothing but the pathology is like systemic pathology. It's not the local pathology in the lung. Whereas exudate, it is a local pathology within the lung itself. That is either pneumonia or the bronchogenic carcinoma. And just now I was discussing about the Light's criteria. If it is positive, it is suggestive of exudative type of pleural effusion. What is that? The pleural fluid protein to serum protein more than 0.5, pleural fluid LDH to serum LDH more than 0.6. And another important thing is the pleural fluid protein that should be more than 3 grams per deciliter. Okay, so this is number 1, this is number 2, and this is number 3. Okay, 1, 2, 3. So out of these 3, at least 1 should be there to consider the Light's criteria to be positive. Okay, then what are the etiologies? So if you take the etiologies of the transudative and exudative, actually there are many causes, but the most common cause for transudate is congestive heart failure. And the most common cause for exudate will be infections like your tuberculosis and as well as the pneumonia, right? Now, following that, you need to know what exactly is the pathophysiology. So pathophysiology, the problem is there will be either excessive entry of the fluid into the pleural space or there will be decreased exit from the pleural space. And decreased exit is mainly because of the blockade within the lymphatics, right? Now, depending upon the constituents of the fluid, the types, if you see, empyema, where you have pus in the pleural space, hemothorax, where you have presence of blood in the pleural space. What is the question here? This is the question. Okay, so to call it as hemothorax, what is the criteria? The hematocrit should be more than 50% of the peripheral blood, right? And another important question is chylus. Chylus means what? It is a milky fluid where there is triglycerides. What should be the quantity of the triglycerides to call it as the chylus effusion? This is a question, right? That is more than 100 milligrams per deciliter should be there. So what will be the clinical features in pleural effusion? Dyspnea will be there because there is reduced chest expansion. So dyspnea. And on examination, what is that you'll notice? On auscultation, you will find that breath sounds are being decreased and you will have a dull note. What type of dull note is that you will have in these patients? In patients with the pleural effusion, you will have a stony dull note. You will have a stony dull note. And what will happen to the vocal fremitus? There will be decreased tactile fremitus. And what will happen to the mediastinum? Mediastinum is being shifted. To which side it is being shifted? It is being shifted to the opposite side. So that will be the clinical features. And if you take the imaging in these individuals, first and foremost, chest X-ray. So chest X-ray is considered as first line investigation. And what is that you will notice in the chest X-ray? In the chest X-ray, you will notice that there is blunting of the costophrenic angle. In the chest X-ray, you will notice that there is blunting of the costophrenic angle. That is the earliest sign. Then what are the other features that you will have in the chest X-ray? You will have presence of homogeneous opacity, presence of Ellis S-shaped curve, and shift of the mediastinum to the opposite side, right? That will be in the chest X-ray. Then how do you manage these patients? So the management of these individuals is you need to treat the underlying cause. But if there is massive pleural effusion causing symptoms, then you need to do pleurisynthesis. But whenever you are doing pleurisynthesis, you should take out the fluid less than 1500 ml per session, not more than 1500 ml. What happens if you take more than 1500 ml out? That can result in re-expansion pulmonary edema. And when will you place the chest tube? You will place the chest tube whenever there is loculated effusion. And then you need to inject the thrombolytic agent. Then when is that you will do a pleurodesis? What is pleurodesis? Where it is obliteration of the complete pleura. So how will you do that? By using the sclerosing agent like talc powder, povidone iodine, doxycycline. These are used as the sclerosing agents. But when will you do that? When there is recurrent effusion, you do this pleurodesis, right? Then coming to specific scenarios like how will you diagnose tuberculous pleural effusion? Very important criteria. The ADA levels in the pleural fluid levels will be elevated more than 45 international units per liter to consider it as tuberculous pleural effusion, right? Or you need to do a TB PCR that will be positive. Then what is the criteria to call it as malignant effusion? You will have the presence of the malignant cells. And what is the most common malignancy that will be causing malignant pleural effusion? That will be your bronchogenic carcinoma and as well as the breast carcinoma. What is hepatic hydrothorax? Hepatic hydrothorax is nothing but those individuals who are having the ascites, they develop the pleural effusion. That is what is called as the hepatic hydrothorax, right? Those individuals with ascites, if they develop pleural effusion, that is called hepatic hydrothorax. Okay, so this is about the pleural effusion, right? So in 1 minute, I'll revise the pleural effusion. Normal quantity of the fluid 5 to 15 ml, right? Clinical detection 300 ml. Lateral view of the chest X-ray 100 ml is required. Frontal view of the chest X-ray 200 ml is required. CT scan of the chest can detect 10 ml of the fluid. Normal pH 7.6 to 7.4. Most common cause for transudate CHF. Most common cause for exudate tuberculosis and as well as pneumonia. Right? Lights criteria very much suggestive of exudative type of pleural effusion. What is that? Pleural fluid protein more than 3, pleural fluid protein to serum protein more than 0.5, pleural fluid LDH to serum LDH more than 0.6. Right? And empyema, pus. Hemothorax, blood. The hematocrit will be more than 50%. Chylothorax, lymph. The triglycerides will be more than 100 milligrams per deciliter. Clinical features will be in the form of dyspnea, diminished blood sound, stony, dull note. First line investigation, chest X-ray, and the earliest manifestation will be blunting of the postophrenic angle. Homogeneous opacity, L is S-shaped curve, mediastinum shifted to the opposite side. Right? So you need to treat the underlying cause. If there is massive pleural effusion, you need to do thoracocentesis. And when you are doing thoracocentesis, you need to take out the fluid less than 1500 ml. Less than 1500 ml. But if you take out more than 1500 ml, that will result in re-expansion pulmonary edema. Right? How will you diagnose tuberculous pleural effusion? ADA levels more than 45 international units per liter. Malignant pleural effusion, you will have this in case of breast carcinoma and bronchogenic carcinoma. Hepatic hydrothorax, you have the ascites causing pleural effusion. Done? That is about the pleural effusion. Chalo, we'll move on to the next topic. Yeah. So what did you people decide? Which of the following is not the feature of tension pneumothorax? Right. So in patients with tension pneumothorax, it's almost like a respiratory arrest. Right? It is like respiratory arrest. So if it's a respiratory arrest, what will happen to carbon dioxide levels? There will be buildup of the carbon dioxide levels. Once the carbon dioxide levels are built up, that will result in the respiratory acidosis in these individuals, but they will not have respiratory alkalosis. Okay, and decreased cardiac output will be there because of increase in the mediastinal pressure, and because of increase in mediastinal pressure, there will be decreased venous return, and breath sounds are absent in patients with the tension pneumothorax. Okay, so, right. So now, what is that we'll be discussing in detail now? Pneumothorax. So, right, those students who have joined now. So let me tell you, the PDF of this particular topic is already available on my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba. So you can download this PDF from my Telegram channel. Right, sure. So starting with the pneumothorax, what exactly is the problem here? That is accumulation of excessive air in the pleural space. Because of the excessive accumulation of the air in the pleural space, the positive pressure is created in the pleural space, and that will cause the collapse of the lung. And what are the types of the pneumothorax? Spontaneous, traumatic, then iatrogenic. Spontaneous, there is no underlying cause, right? Whereas secondary, there is some underlying cause causing pneumothorax, right? Traumatic, due to injury to the chest. Iatrogenic, following medical procedures like placing the central venous catheter. During pleurisynthesis, there can be development of pneumothorax, that is called iatrogenic. Okay, so in primary spontaneous pneumothorax, you have rupture of the subpleural blebs. In secondary pneumothorax, you have the underlying lung pathology like COPD, tuberculosis, malignancy. And in traumatic pneumothorax, there will be blunt or penetrating trauma to the chest. Whereas in the iatrogenic pneumothorax, that is during thoracocentesis or when you have placed the individual on mechanical ventilator. Okay. Now, you take tension pneumothorax. It is a very important medical emergency. These patients, the pleural pressure exceeds the venous pressure. That is the reason why there will be compression of the lung and there will be reduced venous return. And these patients, they require immediate intervention. You need to take a wide bore cannula, right, or wide bore needle, and you have to puncture the second intercostal space in the mid-clavicular line. That is an emergency treatment that you have to do in patients with the tension pneumothorax. So what is the clinical manifestation? The clinical manifestation will be sudden onset dyspnea, right? And because of this dyspnea, these patients, they'll have tachycardia and as well as tachypnea and tachycardia as well. So because lung is collapsed, in pneumothorax, lung is collapsed. Because lung is collapsed, you will notice that the chest wall movements are completely diminished. Chest wall movements are completely diminished. Okay. And breath sounds will be absent because lung is collapsed. And there is excessive air in the pleural space that will give rise to the hyperresonant type of percussion note. In trachea, it will be deviated to the opposite side in case of pneumothorax. And how will you diagnose these patients? So diagnosis of these patients is by the chest X-ray. Chest X-ray, what all you will have? Increased radiolucency, absence of the bronchovascular markings, trachea being shifted to the opposite side. All these are the findings. Whereas ABG, what it will show you that there is respiratory alkalosis, except in tension pneumothorax. In tension pneumothorax, you'll have respiratory acidosis. And when you take the chest X-ray in supine position, there can be radiolucent costophonic angle. That is because of the excessive air in the costophonic angle. You'll have what is called this deep sulcus sign. Then how do you treat? Treatment completely depends upon the severity of the pneumothorax. If the individual is having small pneumothorax, just oxygen therapy will be enough and observation. But if the patient is having moderate form of pneumothorax, these patients, they will be requiring the needle aspiration. And if the individual is having severe form of pneumothorax, where more than 50% of the lung is being collapsed, then in such case, chest tube insertion has to be done. And chest tube insertion has to be done via fifth intercostal space, mid-axillary line. Okay, so that is about when you have to place the chest tube. Then what are the complications? Very important complication is tension pneumothorax. It's a life-threatening condition, right? And there can be pneumomediastinum. So whenever there is esophageal or bronchial rupture, that can result in the development of the pneumomediastinum, right? Then in recurrent cases, you require thoracoscopy or thoracotomy, right? Recurrent cases, you need to do pleurodesis. What is this pleurodesis? You will obliterate the pleura with the help of a sclerosing agent. And very important precautions, if the individual is a smoker, please ask him to avoid smoking completely. And the individual should not go to high altitude. That can increase the recurrence of pneumothorax, right? And how will be the prognosis in these individuals? 30% of recurrence after the observation or the tube thoracostomy. Okay, so there is chance of recurrence. What is the chance of recurrence? Almost 30%, right? So that is about the pneumothorax. Okay, right. Brains, actually, according to your ATLS guidelines, according to ATLS guidelines, that is Advanced Traumatic Life Support Guidelines, what they give you is the second intercostal space for the chest tube insertion. But what Harrison mentions, I'll tell you. Harrison mentions second intercostal space for using a wide bore cannula and puncturing the pleura. And for placing the chest tube, fifth intercostal space, mid-axillary line. These are the lines in the Harrison. Okay, but ATLS guidelines, they are slightly different. But from the medicine point of view, we just follow the Harrison, right? Now, that was about the pneumothorax. The next topic for the discussion will be bronchiectasis. So 1 minute, pneumothorax done. Spontaneous pneumothorax, primary and secondary. Primary, no lung pathology. Secondary, underlying lung pathology. Traumatic due to injury. Iatrogenic following the medical procedures. Tension pneumothorax, very critical condition, where there is raised mediastinal pressure, decreased venous return, decreased cardiac output, hypotension can be there. And these patients, they require immediate intervention. And clinical features in pneumothorax, sudden onset dyspnea. Chest wall movements will be reduced, hyperresonant node will be there, and breath sounds are absent. Tachypnea and tachycardia will be there. Diagnosis, chest X-ray, where you will be hyperlucent lung fields, absent bronchovascular markings, right? There will be collapsed lung, mediastinum being shifted to the opposite side. ABG shows respiratory alkalosis, but in tension pneumothorax, it is respiratory acidosis. When you take a chest X-ray in supine position, you will have deep sulcus sign. Management, small pneumothorax, observation and oxygen therapy. Moderate pneumothorax, they need needle aspiration. Severe form of pneumothorax, chest tube insertion has to be done. Right? Very important complication is tension pneumothorax. Okay. Recurrent cases, pleurodesis has to be done. Precautions, avoid smoking and avoid going to high altitude. Right? That is about the pneumothorax. Going to the next topic, that is bronchiectasis. Right. So how is the session going on as of now? Everything all well? Because the number is falling down. I'm not so happy with the number falling down. Am I doing well or am I going fast? How is the session going on? Okay, right. Please answer this question. Okay, yes. So we have a 29-year-old married male presents to the clinic with complaints of recurrent chronic cough with expectoration for past 10 to 12 years. On auscultation, there is bilateral wheeze, right basal crackles or audible, with heart sounds best heard on the right side of the chest. The CT, okay, heart sounds on the right side of the chest. CT chest reveal dextrocardiac nodular opacities in bilateral lung fields such as bronchiectasis. He also gives history of not having child despite married for the last 4 years. Which of the following could be the possible cause of the infertility in patients with the above syndrome? Oligospermia, blockage of epididymis, asthenospermia, undescended testis. Yes, anyone? Yeah, so very good, Rishi Gautam. So the diagnosis in this patient is Carter-Jenner syndrome. Right? So diagnosis will be the Carter-Jenner syndrome. Okay. So in case of Carter-Jenner's, what are the components? That is ribs. What is ribs in Carter-Jenner's? That is rhinosinusitis. I stands for infertility. Right? B stands for bronchiectasis. S stands for situs inversus. S stands for situs inversus. And that infertility, what exactly is the reason? The infertility, particularly in case of males, it is mainly due to the asthenospermia. What is asthenospermia? Where there will be poor sperm motility, right? Why there is poor sperm motility in these patients? That is due to missing dynein arms. Okay, due to missing dynein arms, what will happen to the sperm motility? There will be poor sperm motility. And that is what is a basic defect in patients with the Carter-Jenner syndrome, right? So now let me take up the discussion of the very important topic, that is bronchiectasis. Okay, right. So yes, so all of you. One second, ad is coming up. Okay, so now you take the discussion related to bronchiectasis. What exactly is your bronchiectasis? Bronchiectasis, it is an obstructive lung disease. And what will be the problem in patients with the bronchiectasis? There will be permanent and irreversible dilatation of the airway, right? Permanent and irreversible dilatation of the medium-sized airway. And what is that medium-sized airway? That is 5th to 9th generation. Okay. And what is the most common cause for bronchiectasis? Most common cause for bronchiectasis will be recurrent infection. That will be recurrent infection. Okay. Then what is the etiology? As I have said you, recurrent infections like tuberculosis, pneumonia, and as well as measles. And the other etiologies include the allergic bronchopulmonary aspergillosis and as well as smoking. And the congenital causes for the bronchiectasis will be cystic fibrosis and then the Carter-Jenner syndrome. And this bronchi or the medium-sized airway, they're abnormally irreversibly dilated. And you know what is the shapes of this abnormal irreversible dilatation? They can be of this any shape: cylindrical, saccular, varicose, and as well as the traction bronchiectasis. But out of all these, the cylindrical bronchiectasis is the most common form of bronchiectasis. And what will be the presentation in these individuals? Presentation in these individuals will be chronic productive cough with purulent sputum. Copious amount of expectoration will be there. And the airway, if you see, the airway is dilated by more than 2 mm. The airway in these individuals, they are dilated by more than 2 mm. When the airway is dilated by more than 2 mm, there can be rupture of these bronchial vasculatures, and that will result in the development of the hemoptysis. And on examination, you will have clubbing and you will have these crepitations. Coarse crackles will be there, right? Coarse crepitations will be there, right? And these crepitations, we describe them as leathery crepitations. We describe them as leathery crepitations. And we have one entity called dry bronchiectasis. Dry bronchiectasis is nothing but the bronchiectasis sicca. In bronchiectasis sicca, you don't have sputum production. Only hemoptysis will be there. Actually, the characteristic feature of bronchiectasis is copious amount of expectoration. But in dry bronchiectasis, you don't have sputum at all. Only blood will be there. Okay. Now, coming to the investigations, number one, the sputum examination. Whenever you just take the sputum in a flask, you will see a 3-layered appearance of the sputum. And chest X-ray will show you a tram track appearance. What is the investigation of choice in patients with bronchiectasis? That is HRCT. Whenever you do HRCT, which is the most accurate test, the HRCT will give you what is called as tree in bud appearance or the signet ring sign. Right, tree in bud appearance or the signet ring sign. Then bronchography is being done mainly for surgical planning. right, for visualization of the bronchus. And what is the most common complication? That is severe hemoptysis. That is due to rupture of the bronchial vasculature. And if there is severe hemoptysis, these patients have to undergo bronchial artery embolization. And not only the lung abscess, the infection from the bronchi can spread to the distant sites also. And that will result in secondary brain abscess and as well as the septic arthritis, right? Then what is the management? See, the most common cause you said like infection. So you need to give antibiotics. And if the bronchiectasis is like localized, what is that you can do? You can do resection of the localized disease. And the next important is chest physiotherapy. The purpose of doing the chest physiotherapy is that the sputum has to be expectorated out. And in advanced cases, when there is bilateral diffuse bronchiectasis, you need to do lung transplantation for widespread disease, right? Then what are the common organisms? The common organisms that will be causing bronchiectasis will be Klebsiella, Staphylococcus, Mycobacterium tuberculosis, and then the Pseudomonas. These are the common organisms that will be causing bronchiectasis. Okay, so this is about your bronchiectasis. So to quickly recap bronchiectasis, right? The investigation of choice is what? The HRCT. And you have to know which particular lobe is commonly affected in HRCT. Sorry, in bronchiectasis, that is left lower lobe. And after the left lower lobe, you have the involvement of the middle lobe. And we were discussing these special syndromes, that is the Carter-Jenner syndrome, where you have the components as ribs. Then we were discussing about, okay, what is this middle lobe syndrome? Middle lobe syndrome is nothing but the Brooks syndrome. Right, middle lobe syndrome is nothing but the Brooks syndrome. And this particular Brooks syndrome, it is secondary to the compression by the tubercular lymph nodes. It is secondary to compression by the tubercular lymph nodes. Okay, then lobar involvement, like this is a very, very important area for the questions. Very, very important area for the questions, right? So upper lobe involvement that is observed in case of post-tubercular bronchiectasis, cystic fibrosis, allergic bronchopulmonary aspergillosis, and radiation fibrosis. Middle lobe bronchiectasis that is observed in Brooks syndrome. Lower lobe bronchiectasis that is observed in case of aspiration and as well as recurrent infections. Okay, so this is about the lobar involvement in patients with the bronchiectasis. So this finishes the topic of the bronchiectasis. So in 1 minute, I'll just revise the bronchiectasis. As such, it's a obstructive lung disease. It's a medium-sized airway disease, right? Where the airways are dilated more than 2 mm in 5th to 9th generation. Most common cause, recurrent infections, right? Then most common shape of this abnormally dilated bronchi, that is cylindrical shape. Most common clinical feature, cough with copious expectoration, and the complication can be hemoptysis. On examination, you'll have clubbing and you'll have leathery crepitations. Right? Dry bronchiectasis means only hemoptysis will be there, sputum production will not be there. Investigation of choice will be HRCT, which will show you tree in body appearance or signet ring sign. Complication will be hemoptysis. Management, if you see medical management, you need to give the antibiotics and then the chest physiotherapy has to be done in order to expectorate the sputum out. And if it is localized bronchiectasis, you can do lobectomy. But in diffuse, it is bilateral, then you need to do lung transplantation. Common organisms are Klebsiella and Staph. Right? And the commonly affected lobe will be left lower lobe. Special syndromes are mainly Brooks syndrome and Carter-Jenner syndrome. And in Carter-Jenner syndrome, please remember the components, ribs. That is rhinosinusitis, infertility, bronchiectasis, and situs inversus. Lobar involvement, upper lobe involvement in post-tuberculous bronchiectasis, cystic fibrosis. Middle lobe bronchiectasis, that is in Brooks syndrome. Lower lobe bronchiectasis, secondary to recurrent aspiration. Okay, so that was about the bronchiectasis. Chalo. Next one. Cystic fibrosis. Yeah, please answer this. So, right. So let me tell you the answer here. The answer is fourth option. Right. Now, what is this particular fourth option? DNAase in patients with cystic fibrosis, we mainly give to decrease the viscosity of the sputum. Right. Then you take this N-acetylcysteine. Right. N-acetylcysteine followed by beta-2 agonist nebulization, that is given mainly to cause the vigorous cough, and then followed by that expectorate the sputum out. Nebulize at 7% saline in cystic fibrosis. For what is the reason that we give in this individual? that is mainly to draw the water into the periciliary mucus. So 7% sodium chloride will cause liquefaction of the sputum, right? Nebulized tobramycin. Nebulized tobramycin, that is mainly to reduce the colonization of the bacteria. To reduce the colonization of the bacteria. Okay. Then, when will you use this handheld oscillometric device? So, handheld oscillometric device, it is mainly used for vibration that helps in mobilization of the secretions. When do we use meropenem in these individuals? We use meropenem if the infection is Burkholderia cepacia. And when do we use this ivacaftor? Ivacaftor, it is given mainly to improve the chloride conductance. Mainly to improve the chloride conductance. Okay, so these are the various treatment options for cystic fibrosis. Now, let me discuss in detail about the cystic fibrosis. So, in cystic fibrosis, what exactly is the problem? The problem in the cystic fibrosis, it is mainly due to defective protein. That is, CFTR protein will be defective, right? And this defective CFTR protein, it is being inherited. How is it being inherited? It is by autosomal recessive type of the inheritance, right? And it's a multi-system involvement. It is not just only the lung which gets affected. Along with the lung, GAT, pancreas, liver, and reproductive system is also being affected in patients with the cystic fibrosis. And the gene that is being defective is CFTR gene. And where is the CFTR gene present? It is present on the chromosome number 7. What is the, this is a PYQ. Where is that? Yeah, this is a PYQ. Okay, so what is that mutation? There will be deletion of which particular amino acid? Which amino acid is being deleted? Anyone? Yes. Now, what is that amino acid? No, not leucine. It is phenylalanine. Right? It is the phenylalanine that is being lost. Okay, it's a PYQ, right? Now, so that is about the genetics. And because of this defective CFTR protein, what is the problem? The problem will be defective chloride and as well as water transport. Now, because of defective chloride and water transport, what will be the problem? There will be thickened mucus. There will be thickened mucus, right? Then, how will be the mucociliary clearance? There will be impaired mucociliary clearance. Why? Because of thick mucus. Because of thick mucus. Okay, next. Now, what will be the features? Lung manifestations that will be in the form of recurrent infections because there is a thick mucus, and in that particular thick mucus, the organism can get deposited, right? And the GAT manifestations, they will have the meconium ileus, where the child will be requiring gastrographin enema, where the child will be requiring gastrographin enema. And these patients, they will also have malabsorption that will result in steatorrhea and as well as diarrhea. What is the abnormality in the pancreas? The abnormality in the pancreas will be exocrine insufficiency of the pancreas that will result in malabsorption, right? And there will be also the endocrine involvement as well. What will be that endocrine involvement? That will be diabetes mellitus. And what will be the hepatic involvement? There will be stasis of the bile. Bile becomes very thick, there will be stasis of the bile, and that will result in the development of the obstructive jaundice, right? Then, how will you diagnose? What is the screening test that you'll be doing in these individuals? That is sweat chloride test. So sweat chloride test on at least 2 occasions, the value should be more than 60 milliequivalents per liter. That is a sweat chloride test, right? Then how will you confirm the diagnosis? The confirmation of the diagnosis, it is by CFTR, right? So DNA testing, it will detect the CFTR mutation. Okay, and the nasal potential difference you'll have when will you do this nasal potential difference? If the sweat chloride test is equivocal, then you do this nasal potential difference, which will demonstrate that there is abnormal ion transport. Next important is the fecal elastase. What is the purpose of fecal elastase? This will detect the pancreatic insufficiency, right? Then what are the complications that you come across in these patients? The individual will have recurrent infections because there is a thick sputum. There will be formation of a biofilm. The other complications will be like pneumothorax, massive hemoptysis, corpal nil, and endocrine abnormality, diabetes mellitus, hepatic abnormality in the form of liver cirrhosis, and infertility can be there. Then how do you treat these patients? So treatment is that you need to give recombinant DNAs, that is mainly to liquefy the sputum, and hypertonic saline that will draw the fluid, that will draw the water across the epithelium, and that will also cause liquefaction of the sputum. Then you need to give this particular ivacaftor. So what is the purpose of giving this ivacaftor? Ivacaftor will improve the chloride conductance. Ivacaftor will improve the chloride conductance, and that is the reason why you need to give ivacaftor, or the other combinations that can be given is the elixacaftor or tezacaftor can be given. Next is antibiotics, like mainly to kill the organisms, because these individuals are more prone for infections. And in advanced disease, what is that you need to do is lung transplantation. In advanced disease, you need to do lung transplantation. Now, because these individuals are at increased risk of infections, you need to give pneumococcal and as well as the influenza vaccination. And what is the median survival of the individual? Median survival will be more than 39 years. And what is the most cause for death in these patients? Most cause for death will be pulmonary complications or the chronic respiratory failure. Pulmonary complications or chronic respiratory failure. So this will be the cause of death in patients with the bronchiectasis. All right. So this finishes the topic of bronchiectasis. The next topic for the discussion will be the bronchogenic carcinoma. So in 1 minute, I'll revise the cystic fibrosis. So cystic fibrosis, autosomal recessive disorder, protein defective CFTR protein, right? And the gene CFTR gene present on chromosome number 7. What is the mutation? Deletion of the phenylalanine on position 508. Right? Then what are the organs affected? Lung, GAT, pancreas, liver, reproductive system. What exactly is the pathogenesis? Defective chloride and as well as water transport. Thereby, there will be a thick secretions. Lung involvement, recurrent infections, bronchiectasis, corpal nil. GAT involvement, meconium ileus in the newborn, malabsorption in adults, and biliary cirrhosis and liver damage. Pancreas, exocrine and endocrine insufficiency. Endocrine, diabetes mellitus. Liver abnormality, biliary stasis causing biliary cirrhosis. Screening test, sweat chloride test. Confirmatory test, DNA testing. If the test is equivocal, then you need to do the nasal potential difference. How will you detect the pancreatic insufficiency? That is by fecal elastase. Complications, recurrent infections, and pneumothorax. Management, you need to give recombinant DNAs and as well as hypertonic saline, mainly to liquefy the sputum. Right? Then ivacaftor, tezacaftor, and elixacaftor, that should be given mainly to improve the chloride conductance. Antibiotics should be given mainly to cut down the infections. In advanced cases, lung transplantation. Repeated infection is there. That is the reason why pneumococcal and influenza vaccine should be given. Right? Median survival will be around 39 years. Okay. So done. So this is about cystic fibrosis. Okay. So coming to the next topic, that is bronchogenic carcinoma. Okay. So what is this bronchogenic carcinoma? As such, it is a malignant neoplasm which is originating from the epithelium of the bronchus and as well as bronchiole. What are the various types that we have? Squamous cell, adeno, small cell, and as well as the large cell carcinoma. Right? What is the most common cause? Cigarette smoking. What are the environmental factors that can cause bronchogenic carcinoma? Most commonly, it is the exposure to the radon gas. Most commonly, exposure to radon gas. Then other environmental exposures will be asbestos and metals like arsenic, chromium, and nickel. What are the histological types? So the most common histological types all over the world will be the adenocarcinoma. And this adenocarcinoma, it is commonly observed in the women and as well as non-smokers, right? And which part of the lung is affected? That is mainly the peripheral part of the lung. Next important is the squamous cell carcinoma. Squamous cell carcinoma, it is associated with smoking. And which part of the lung is affected? Central part of the lung is affected in squamous cell carcinoma. Next important is the small cell carcinoma. In small cell carcinoma, which is a highly aggressive tumor with worse prognosis, which part of the lung is affected? Central part of the lung is affected and worse prognosis will be there. Next important is large cell carcinoma, which is poorly differentiated and it's a peripheral tumor. That is about the histological types. So adenocarcinoma, squamous cell carcinoma, small cell carcinoma, and large cell carcinoma. Right? Then coming to the symptoms, you have central tumors and as well as the peripheral tumors. Okay. So central tumors, what will be the presentation? Cough, dyspnea, wheezing. And because of the obstruction, there can be development of pneumonia. Whereas you take in the peripheral tumors are the one, they can spread to the pleura. So when these peripheral tumors, when they spread to the pleura, these patients will develop the pleuritic pain, right? Where there will be chest pain. So that will be the peripheral tumors, right? Then followed by that, okay. Then followed by that, we have some special syndromes. What are these special syndromes? Pancoast and as well as the superior vena cava syndrome. Okay. So Pancoast syndrome, it is nothing but the apical tumors, which is observed in case of adenocarcinoma. These apical tumors will be compressing the cervical sympathetic chain. That will result in the development of the Horner syndrome, and there will be compression to the nerves which are coming down to the upper limbs, and that will result in the shoulder pain and as well as the arm pain. Next is superior vena cava syndrome, which is very common in small cell carcinoma. And this superior vena cava syndrome, it will be compressing the structures which are present within the mediastinum. And once the structures within the mediastinum is being compressed, there will be like swelling of the face, neck, arms, and there will be dilated chest veins. Right? Where is it observed commonly? Small cell lung carcinoma. Then you need to know the paraneoplastic syndromes. Small cell lung carcinoma will produce excessive amount of ACTH that will result in Cushing's. Small cell carcinoma will produce excess amount of the ADH that will result in SAADH causing hyponatremia. And the other one is Lambert-Eaton myasthenic syndrome, which is a presynaptic nerve terminal disorder. Okay. Then squamous cell carcinoma can also cause the paraneoplastic syndrome. It will produce parathormone related protein that will result in hypercalcemia. Then you take the first line investigation will be like chest X-ray, which will show you some opacity, right? And HRCT is the one which will help in evaluating the size and as well as the spread of the tumor. And if you take the sputum cytology, so sputum cytology, which almost 5 samples are required, but the sensitivity is very bad. 69% only is the sensitivity. Next is the biopsy. Okay, but biopsy is considered as the investigation of choice, right? You need to do a bronchoscopy and biopsy. That will tell you what exactly is the type of the tumor. And the treatment, if you take, now these individuals with small cell carcinoma, it's a highly aggressive tumor. So there is a rapid spread. So you need to give chemotherapy. And the chemotherapy that you give is the etoposide plus cisplatin or carboplatin. And the other treatment options are radiation and as well as surgery. Right? But this surgery, it is ineffective because it is spread. Whereas non-small cell lung cancer, it's a localized tumor. So that is the reason why surgical resection has to be done if it is localized. But you need to give chemotherapy if it is been spread. Chemotherapy should be done if it is spread. Like paclitaxel plus carboplatin should be given. What are the complications in case of bronchogenic carcinoma? When there is a local invasion that can cause pleural effusion, malignant pleural effusion. The other ones are SVC syndrome. And there can be a distant spread also from bronchogenic carcinoma, that is to the liver, brain, and adrenals. And these are associated with paraneoplastic syndromes, right? Which type of bronchogenic carcinoma is considered to have a poor prognosis? Small cell lung cancer. Which type of bronchogenic carcinoma is considered as the better prognosis? That is squamous cell carcinoma. Okay, so this is about the bronchogenic carcinoma, right? So let me just quickly recap bronchogenic carcinoma in just 1 minute. Okay, bronchogenic carcinoma, malignant neoplasm arising from epithelium of bronchus and bronchiole. Most common adenocarcinoma all over the world. In India, most common squamous cell carcinoma. Most common risk factor, cigarette smoking. Most common environmental risk factor, exposure to radon gas. Adenocarcinoma, most common type, peripheral tumor, most common in women and non-smokers. Squamous cell carcinoma, central tumor, common in smokers. Small cell carcinoma, worst prognosis, central tumor, common in smokers. More aggressive. Large cell carcinoma, it's a poorly differentiated tumor, both peripheral and as well as central, right? So symptoms, if you take central tumors cough, peripheral tumors chest pain. Pancoast syndrome, it is commonly observed in apex tumors or the adenocarcinoma where there will be Horners. Then superior vena cava syndrome observed in small cell lung cancer where the individual will have swelling of the face and neck because of the compression of the superior vena cava. Investigations, if you see, the investigation of choice will be bronchoscopy plus biopsy. And treatment, in case of small cell lung cancer, you need to give chemotherapy. That is etoposide plus cisplatin plus or carboplatin, and radiation therapy should be given. Non-small cell lung cancer, the surgical resection should be done if the disease is localized. If it is like widespread, you need to give paclitaxel plus carboplatin. Okay, so that is about the bronchogenic carcinoma. Yeah, will this be enough for FMG? More than enough, right? Yeah, chalo. We'll move on to the next topic, that is pulmonary embolism. Yes, please answer this. 55-year-old patient presents with acute onset chest pain and dyspnea. Case of pulmonary embolism, hemodynamically stable. Initial imaging of choice in the given scenario. Very good. So the investigation of choice in patients with the hemodynamically stable pulmonary embolism will be CTPA, that is computed tomography, pulmonary angiography, right? That is the initial imaging modality of the choice for stable patients, right? And next important is, but you have to understand this pulmonary angiography is an invasive procedure, whereas your HRCT is a non-invasive procedure, but pulmonary angiography is an invasive procedure. Now, let us start with the discussion related to pulmonary embolism. Right. So pulmonary embolism, what exactly is the problem? It is the obstruction of the pulmonary artery by the embolus, right? And what is a common source for the embolus into the pulmonary artery? That is from the lower limbs. That is deep vein thrombosis. Okay. Then you have acquired causes and inherited causes. Acquired causes are mainly like surgery, trauma, immobilization, pregnancy, and oral contraceptive pills, which are rich in estrogen. And inherited causes will be mainly the hypercoagulable states, like factor V lead-in mutation, protein C proteinase deficiency, antithrombin 3 deficiency. That will be the inherited causes. What will be the clinical features that you will have in these individuals? Okay, so the clinical features that you will have in these individuals will be sudden onset dyspnea, that is particularly observed in case of massive pulmonary embolism, right? And most common sign will be tachypnea. And if there is massive pulmonary embolism, these patients will be having hypotension and there will be vascular collapse. And there will be also elevated JVP due to right heart failure, right? And P2 will be loud. Why P2 will be loud? Due to pulmonary arterial hypertension. So now, how do you classify pulmonary embolism? That is massive, submassive, low risk. Massive pulmonary embolism, along with hypotension, there is right ventricular dysfunction and high mortality. Submassive pulmonary embolism, there will be RV dysfunction, but blood pressure will be normal. Whereas in low risk pulmonary embolism, blood pressure normal, right ventricle is also normal. Okay, that is in low risk pulmonary embolism, right? Then how do you work up? So the initial test will be D-dimer, but it is not specific because D-dimer is elevated in multiple conditions. Definitive test is CT pulmonary angiography. But if you are not able to do CT pulmonary angiography, ventilation perfusion scan has to be done. ECG, what is that you will have? Right, ECG, you will have the sinus tachycardia. Rahul, you want me to change my background? You didn't like, okay, I'll change for you, no problem. Chalo. Okay, so, right, then what will be the most specific finding? Is this fine or am I merging in the background? Okay. Yeah, outer space. Right, fine. So most common ECG finding, right? Most common ECG finding will be sinus tachycardia. But in massive pulmonary embolism, you will have S1Q3T3 pattern, and then you will have the right heart strain pattern, that is right bundle branch block, and there will be also right axis deviation. What will be the chest X-ray finding? The chest X-ray finding that will be in the form of the Hampton sum, where there will be a wedge-shaped opacity. Western mark sign, that is focal oligemia, right? Palas sign, where there will be enlarged right descending pulmonary artery. That will be the chest X-ray finding, right? Then, how do you treat these patients? Massive pulmonary embolism, where there is hypotension and right ventricular dysfunction, you need to do thrombolysis. And subsequently, you need to give anticoagulants later. Submassive pulmonary embolism, only anticoagulants, you don't require to do thrombolysis. Right? But if there is recurrent pulmonary embolism, then you need to place the individual on IVC filters. So overall, what will be the complications? RV failure is a very important complication. And in chronic cases, there will be chronic thromboembolic pulmonary hypertension. Okay. And how will be the mortality? Mortality varies depending upon the risk category. mortality varies depending upon the risk category. Okay, so this will be the prognosis in this individuals. So this finishes the topic of pulmonary embolism. Okay, so 1 minute I'll revise the pulmonary embolism. What is pulmonary embolism? Obstruction in the pulmonary artery. Where is it coming from? Most commonly in the from the lower limbs, and that too in the iliac veins or from the pulmonary veins. Right? The acquired causes will be like surgery, trauma, immobilization, pregnancy. Inherited causes will be hypercoagulable states like factor V Leiden mutation, protein C proteinase deficiency, and antithrombin 3 deficiency. Clinical features most common will be sudden onset dyspnea, right? And most common sign will be tachypnea, right? And if you take the types of pulmonary embolism, massive pulmonary embolism, you will have hypotension and RV dysfunction. Submassive pulmonary embolism, blood pressure normal, RV dysfunction will be there. Low risk pulmonary embolism, normal hemodynamics, no RV strain. Investigation of choice, CT pulmonary angiography. Second line investigation, ventilation perfusion scan. Most common ECG finding, sinus tachycardia. Massive pulmonary embolism, ECG will show you S1, Q3, T3 pattern. Chest X-ray, you should know all the three signs, Hampton sum, Western Mark sign, Pallas sign. And the treatment, if you see, massive pulmonary embolism, you need to do thrombolysis. Submassive pulmonary embolism, you need to give anticoagulants like heparin and low molecular weight heparin. Recurrent pulmonary embolism, you need to place the individual over the IVC filter. And complications will be RV failure. Okay, so that was about the pulmonary embolism, right? Now, we'll move on to the next topic, that is fat embolism syndrome. Yeah, answer this. What will be the diagnosis in a patient with fractured femoral shaft who developed sudden altered sensorium, sudden onset dyspnea, and petechiae that are predominantly found in the axillary region compared to the rest of his body? Very good. So as we are discussing fat embolism syndrome, the answer should be definitely fat embolism syndrome only, right? Chalo. Now, what exactly is the problem in the fat embolism syndrome? So in fat embolism syndrome, the problem will be, it is a systemic inflammatory response which is caused by presence of the fat droplets in the circulation. That fat droplets, they are the one which will induce the systemic inflammatory response. And what is the cause for fat embolism syndrome? Very importantly, polytrauma. Other causes, pancreatitis, hypertriglyceridemia, where the triglyceride levels are elevated more than 500 milligrams percentage, liposuction. Right? These are all the various etiologies. Pathogenesis is that mainly from the fat, you have the release of the free fatty acids. They are the one which will cause damage to the capillary endothelium. And these fat emboli can also enter into the CNS, causing CNS manifestations. Right? Then what is the name of the criteria for the fat embolism syndrome? That is Gerd and Wilson's criteria. You have major and as well as minor criteria. So according to major criteria, you have like respiratory distress, CNS involvement in the form of coma, petechia will be there mainly over the axilla, then compared to the rest of the body. Then followed by that, the minor criteria. So in the minor criteria, you'll have tachycardia, fever, retinal changes, jaundice, anemia, thrombocytopenia, and there can be fat in the urine or sputum. And how will you diagnose? Chest X-ray, normal or diffuse infiltrates. CT scan will show you ground glass opacities. CT of the head will show you white matter petechia because there is fat embolism. Transesophageal echocardiography, that will show you the presence of PFO, patent foramen ovale. Bronchoalveolar lavage, that is useful for staining the fat. Then how do you treat these patients? Right? How do you treat these patients? You need to give high flow oxygen, that is 12 liters per minute is the oxygen that we give. Right? Then IV fluids have to be given for hydration. Right? And steroids have to be given mainly for the cerebral edema. Heparin should be given for anti-lipemic effect. Heparin should be given for anti-lipemic effect. Right? Compression stockings mainly to prevent the deep vein thrombosis. Right? Proton pump inhibitors like the pantoprazole mainly to prevent the gastrointestinal stress ulcers. And complications will be like respiratory failure and as well as multi-organ dysfunction. That is what you'll observe in case of the fat embolism syndrome. So the very important part of the discussion, let me just quickly revise. What exactly is this? Inflammatory response to fat droplets. Most common cause, polytrauma and fracture to the long bones. Pathogenesis, free fatty acids are the one which will be damaging the capillary endothelium. Name of the criteria, Gerd and Wilson's criteria. Major and minor criteria will be there, right? And the confirmation can be done by the CT chest that will show you the presence of ground glass opacities. High flow oxygen, IV fluids, steroids should be given, right? And for anti-lipemic effects, you need to give heparin and compression stockings to prevent the deep vein thrombosis. Okay. So this is about your fat embolism syndrome, where you have the very important criteria, that is GERD and Wilson's criteria. Chalo, done. That is about the fat embolism syndrome. So take the next topic, respiratory failure. Yes, answer this. Respiratory distress, cardiogenic shock. Which type of respiratory failure is primarily caused by underperfusion of respiratory muscles? Caused by underperfusion of respiratory muscles. Very good. So in case of the cardiogenic shock, the type of respiratory failure that you will have is type 4 respiratory failure, where there will be underperfusion of the respiratory muscles, right? Now, so if you take the types of respiratory failure, you have totally 4 types, right? So what are these 4 types? Number 1, your type 1 respiratory failure, which is hypoxemic respiratory failure. So in hypoxemic respiratory failure, you will have hypoxia and as well as the hypocapnia. Hypoxia and hypocapnia. And what will happen to your AA gradient? AA gradient is increased. Alveolo-arteriolar gradient will be increased. Right? Type 2 respiratory failure is hypercapnic respiratory failure, where there will be hypoxia and hypercapnia. Whereas in type 1, the carbon dioxide levels, either it might be low or the carbon dioxide levels can be normal also. Either it might be low or the carbon dioxide levels can be normal also, right? Whereas type 2, you will have hypoxia and as well as hypercapnia. And what will happen to your A gradient? A gradient will be normal, right? A gradient for oxygen will be normal in case of type 2 respiratory failure. What are the etiologies? So if you take the etiologies for type 1, you have ARDS, pneumonia, and pulmonary edema. Whereas for type 2, the etiologies will be severe form of COPD, not mild or moderate, severe form of COPD, obstructive sleep apnea, and neuromuscular defects. Type 3 is considered as the perioperative respiratory failure, and that is due to atelectasis in the postoperative period. And type 4, it is shock related, and that is due to hypoperfusion of respiratory muscles. That is due to hypoperfusion of respiratory muscles. So these are the 4 types, type 1, 2, 3, and as well as 4. So this particular table will give you the etiology and as well as the clinical features. So type 1, as I have said you, it is ARDS, pulmonary embolism, pneumonia, and pulmonary edema. So in case of type 1, you have the alveolar flooding, right? You will have alveolar flooding. Whatever the etiologies that you have there, ARDS, pulmonary embolism, pneumonia, pulmonary edema, you have alveolar flooding there. Whereas in type 2, you have alveolar hypoventilation, right? You will have alveolar hypoventilation, like chronic bronchitis, OSA, myasthenia gravis, Guillain-Barré syndrome, severe asthma. And type 3, it will be perioperative respiratory failure, like obesity, anesthesia, and abdominal surgery. Type 4 will be secondary to cardiogenic shock or secondary to sepsis. And in all these etiologies, the common symptom will be dyspnea. But whereas in type 2, they'll have drowsiness, headache, and confusion. Why they will have drowsiness, headache, and confusion? That is because of increase in your carbon dioxide levels. And type 3 is considered as postoperative respiratory failure. There will be atelectasis of the lung field, collapse of the lung field. And type 4, you have respiratory muscle fatigue that will result in lactic acidosis. Why there is respiratory muscle fatigue? Because there is reduced perfusion of the blood to the respiratory muscles, right? That is the reason why there is respiratory muscle fatigue. Then, coming to the diagnostic test. So ABG is the one which will help us to assess. There will be hypoxia and as well as hypercapnia. That is mainly in type 2. Whereas in type 1, you will have hypoxia and as well as hypocapnia. What will be the imaging studies? That is chest X-ray and as well as CT scan. And polysomnography is done mainly to assess the obstructive sleep apnea, because obstructive sleep apnea, it is the etiology that will be responsible for type 2 respiratory failure. Then how do you treat? For all the types of respiratory failure, you need to treat the underlying etiology, followed by that oxygen therapy and as well as mechanical ventilation, right? And in type 2, you need to treat the underlying etiology and you need to place the individual on non-invasive ventilator, either with the help of CPAP or BiPAP. Whereas in type 2, like oxygen therapy and then chest physiotherapy has to be done, mainly to improve the strength of the respiratory muscles. And type 4, which is secondary to cardiogenic shock, whenever you do a mechanical ventilation, there will be improvement in the cardiac output in these patients with type 4 respiratory failure. And what will be the complications? Any form of the respiratory failure, there will be hypoxia. So that will cause pulmonary arterial hypertension. Okay. So this is about your respiratory failure. Done? Right. So please tell me the next question. Right. So answer. Hmm? So which association are correctly paired with their clinical scenario and associated pathogens? Right. So the correct associations are whenever there is poor dental hygiene. Right. So whenever there is poor dental hygiene, that is associated with the development of the chlamydia and as well as Klebsiella pneumonia, right? And structural lung disease, it is associated with, right? Structural lung disease that is associated with Burkholderia, whereas you take the other options, aspiration pneumonia. You take the other options, that is aspiration pneumonia. What is the most common organism that will be causing aspiration pneumonia? Aspiration pneumonia, it is mainly caused by the oral anaerobes. Mostly caused by the oral anaerobes and as well as the gram-negative organisms. That will be aspiration pneumonia. Whereas you take in case of the heavy alcohol use. In case of the heavy alcohol use, right? Heavy alcohol use that will lead to depressed level of the consciousness. There will be depressed level of the consciousness. Okay, so in those individuals with the heavy alcohol use, the organisms are mainly strep, right, or the oral anaerobes, right, or the oral anaerobes and Klebsiella pneumonia. That is in case of the heavy alcoholics, right? And poor dental hygiene, right? It is the correct one, that is chlamydia and as well as Klebsiella. And structural lung disease, Burkholderia. Okay, and I have given you one table which is very, very important, right? So this, okay, so this notes is available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, and you can just download it from there. So alcoholism, strep, oral anaerobes and Klebsiella. COPD, Haemophilus influenza, Pseudomonas, chlamydia, very common. Structural lung disease, Burkholderia, Pseudomonas, staph. Patients with dementia and decreased level of consciousness, oral anaerobes, gram-negative organism. Patients with the lung abscess, it is community-acquired methicillin-resistant Staphylococcus aureus, then oral anaerobes, then Mycobacterium tuberculosis and atypical mycobacteria. So these are all the organisms, right? Yeah. Ali, you want the one with annotations? Okay, fine. I'll send it on the Telegram channel once my session is over, right? Yesterday's session. Okay. Sure. We'll start with the discussion related to pneumonia. So what exactly is the pneumonia? So it is the inflammatory condition of the lung, right? Where because it's an infectious pathology, you'll have fever, chest symptoms, and you'll have the consolidation that will be visible on the chest X-ray. What are the types of pneumonia? The types of pneumonia that you will have is lobar, broncho, and interstitial, right? So you take lobar pneumonia. So in case of lobar pneumonia, very important is consolidation. Consolidation which is confined to one lobe or more lobes. Bronchopneumonia, you will have the patchy consolidation. Consolidation is not confined to one lobe. Whereas interstitial pneumonia, where the problem will be within the interstitial tissue. Where the problem will be within the interstitial tissue. Common organisms are, if you take the community-acquired pneumonia, the common organism is the strep pneumonia, right? And the other options are like Haemophilus influenza, Mycoplasma pneumonia. And for nosocomial pneumonias, the most common organism will be Pseudomonas, Klebsiella, and as well as Staphylococcus aureus. That is for nosocomial pneumonias, right? So what is the most common organism that will be causing community-acquired pneumonia? That is Streptococcus pneumonia, right? Next. Now, organisms, depending upon the sputum color, rusty sputum, Streptococcus pneumonia, red currant jelly, Klebsiella, Green sputum, bacterial infections or Pseudomonas or Haemophilus influenza. Yellow sputum, bacterial infections. Pink frothy sputum, pulmonary edema. And what are the risk factors for the development of the pneumonia? The individual's immunity should be compromised for the development of the pneumonia. What is that scenario? Advanced age. Or the individual should be a smoker, or the individual with a chronic disease, or the individual should be having the immunosuppression and alcohol use. So what will be the common clinical scenario? The common clinical scenario will be fever, productive cough, and you will have crackles. Why? Because you have the inflammatory exudate within the alveoli that results in crackles, right? Color of the sputum I have already discussed. How will you diagnose? X-ray, which will show you the consolidation, where you have the presence of air bronchograms, that is mainly in the lobar pneumonia. Blood test, when you do, you'll have polymorphonuclear leukocytes. Sputum analysis, that is mainly to decide the gram stain. And in which scenario you need to do urinary antigen test? The urinary antigen test, it has to be done for pneumococcal and Legionella pneumonia if the sputum production is not observed. Usually in pneumococcal pneumonia strep, you'll have sputum production. But in case of Legionella pneumonia, when sputum is, Legionella pneumonia is the one which will be causing interstitial pneumonia. You'll have dry sputum. Dry cough. There is no sputum production. So in such case, you can do urinary antigen test. And how do you treat these patients? The antibiotics. And that is completely based on culture and sensitivity, right? Then the other important complications will be like lung abscess, empyema, and as well as the ARDS. These are the complications. And how do you prevent? See, the most common organism is pneumococcus. So you need to give vaccination. We have two types of the pneumococcal vaccine, but the very important is pneumococcal, right? Pneumococcal polysaccharide vaccine. And this pneumococcal polysaccharide vaccine, that should be given for adults more than 65 years and as well as even for high-risk groups. And annually, you need to give the influenza vaccine. Annually, you need to give the influenza vaccine. Okay, so this is about the prevention. And what is the indication? As I have said, you elderly individuals and high-risk groups, like those individuals with chronic heart, lung, liver, kidney disease. Then immunocompromised individuals like HIV, cancer, and asthenia. And those individuals with cochlear implants, CSF leak, and post-splenectomy patients. Okay, so these are the indications for the pneumococcal vaccine. And very, very important discussion will be the curve score. Very, very important discussion will be curve score. So curve 65, right? That is confusion. U stands for urea, R stands for respiratory rate, B stands for blood pressure less than 90/60, A stands for the age of the individual more than 65 years, right? Now, if the score of the individual is like 0 to 1, outpatient treatment is enough. If the score is 2, you need to admit the patient to hospital and give IV antibiotics. If the score is 3, you need to admit the patient to ICU and then you should give IV antibiotics. Okay, so this is about the story related to pneumonia, right? So pneumonia is done. Right. Now, moving on to the next topics, that is the tuberculosis. The expected questions. Okay. Just give me some time, Lokesh. So once these rapid revision sessions are over, then I'll do some expected PYQ sessions as well. Okay. Or expected MCQ sessions also I'll do. Right. Answer this. We have a 67-year-old man presented to the OPD with complaints of chronic cough and fatigue for 2 weeks. He was recently diagnosed with the pulmonary tuberculosis and treated with 4-drug anti-tubercular treatment. The patient stated he had small amounts of blood-streaked sputum for the past 2 weeks, but immediately before coming to the emergency department, he had coughed up large volume of the blood that is estimated to be 250 ml of the fresh blood. The procedure of the choice for controlling the massive hemoptysis in this case is, yes. What is that you want? Massive hemoptysis. So for the control of massive hemoptysis, please remember what is that you have to do is bronchial artery embolization has to be done. Bronchial artery embolization has to be done for the treatment of the massive hemoptysis. Okay. So when do you call massive hemoptysis? When the blood which is expectorated out is like more than 200 ml or in the range of 300 ml, then we use the word massive hemoptysis, where the individual will be requiring bronchial artery embolization. So in case of tuberculosis, what is the various routes of spread of tuberculosis? One is your droplet route, right, where the organism can enter into lung, tonsil, or lymph node. Ingestion, where the individual will develop ileocecal tuberculosis. Vertical transmission, where the liver of the fetus is the first common organ which is affected. Right, liver of the fetus which is commonly affected. Next is direct contact, where there will be like skin tuberculosis. That is called lupus vulgaris. That is called lupus vulgaris. Okay, that is about the transmission. Coming to the risk factors, one is age, either children or elderly individuals, because immunocompromised state like HIV, diabetes, silicosis, malnutrition, these are all the risk factors. Then, what are the forms of tuberculosis? Primary tuberculosis, where you will have initial infection, and often these are asymptomatic. Then, latent tuberculosis infection, where the bacilli is completely not at all active. Active tuberculosis, where the individual will have symptomatic pulmonary tuberculosis. Reactivation tuberculosis, where the dormant bacilli will become active. The dormant bacilli will become active. Right? So these are the forms of the tuberculosis. Primary, latent, active, reactivation. What will be the common symptoms in tuberculosis? Cough with sputum more than 2 weeks, night sweats, evening rise of temperature, weight loss, hemoptysis, and fatigue. And what is the most common site for the extrapulmonary tuberculosis? That will be lymphatic spread. And the other organs will be like pleura, genitourinary organs, and as well as meninges. These are the sites for the extrapulmonary tuberculosis. What are the diagnostic tests? The diagnostic test will be the sputum smear examination. But what is the investigation of choice in tuberculosis? The investigation of choice will be like the gene expert, which is nothing but CBNAT. Right, which is nothing but the CBNAT. That will be the investigation of choice. That is cartridge-based nucleic acid amplification test. So what will be the first line treatment that you will be giving in these individuals? Isoniazid, rifampicin, pyrazinamide, and ethambutol. Second line drugs will be amikacin, fluoroquinolone, and ethionamide. Right? Then what can anyone tell me what are the new drugs that we give for tuberculosis? Anyone? What are the new drugs which are given in the treatment of tuberculosis? Yes, new drugs given in the treatment of tuberculosis. Right. So the new drugs that we have in the treatment of tuberculosis are pretomanid, then bedaquiline, right? So these are the new drugs, pretomanid and as well as the bedaquiline, right? Now, what are the complications, expected complications? Hemoptysis, pleural effusion, miliary dissemination, and as well as the pneumothorax. Now, in case of the tuberculosis, the important discussion will be the types of lesions in tuberculosis. So, if you take the types of lesions, Gons focus, where is the common site for the Gons focus and what does the Gons focus contain? It's a granuloma with central caseation. That is Gons focus. And where exactly is your Gons focus? The Gons focus will be in the lower part of the upper lobe or the upper part of the lower lobe. Right, lower part of the upper lobe or upper part of the lower lobe. That is the Gons focus. Next, like what you have is Gons complex. Gons complex is that where along with the Gons focus, you have associated lymph node granuloma, associated hilar lymphadenopathy. Okay, along with Gons focus, you have associated hilar lymphadenopathy. That is Gons complex. What is Ranke's complex? It's a calcified Gons complex. It is called Ranke's complex. Then Simon focus. Simon focus is that where there will be reactivation of the tuberculous lesions seen in the lung apex. That is called Simon focus. Asmon focus. You have infraclavicular focus that is being reactivated. So the region will be in the infraclavicular region. Pulse lesion. That is supraclavicular focus. And where will you have that pulse lesion? Supraclavicular region. Next is the rich focus, where you have tuberculous granuloma within the meninges. Tuberculous granuloma within the meninges. Okay, so that is nothing but tubercular meningitis. V-gut focus, where you have the metastatic foci within the pulmonary vein. Right? Then when do you call miliary tuberculosis? We use the term miliary tuberculosis when the size of the nodules within the lung parenchyma is less than 2 mm. And that is being scattered throughout the lungs. And what is the route of spread in case of miliary tuberculosis? That is hematogenous spread. And what are the common organs where the organism can spread? Lung, liver, spleen, and as well as the kidney. These are the sites where there can be miliary tuberculosis. Right? Next is the tuberculomas. So if you take this tuberculomas, this is a localized mass-like lesion with central caseation. Localized mass-like lesion with central caseation. Right? So where are these tuberculomas very common? Lung and as well as brain. These are the places where you have the presence of the tuberculoma. Okay, right. Okay, so this is about the tuberculosis. So in case of the tuberculosis, you need to know the various routes of spread: droplet, ingestion, vertical, direct. Risk factors mainly elderly and children, HIV, diabetes, silicosis. Forms of tuberculosis: primary, latent, active, reactivation. Common symptoms like cough, fever. Extrapulmonary, the most common will be lymph nodes. Investigation of choice, gene expert, that is CBNAT. First line and second line drugs, right? New molecule will be predominant and as well as bidaquiline. Complications like hemoptysis and pleural effusion and miliary dissemination. Then you need to know all these lesions: Gons focus, Gons complex, Ranke's, Simon, Asman, pulse lesion, Rich, V-gut, miliary, and tuberculoma. Okay, so that is done with the tuberculosis. Right. Now, we'll move on to the last topic of the discussion in the pulmonology, that is the interstitial lung disease. Right. Answer this. A 38-year-old female patient presents to the OPD with a productive cough and dyspnea. Chest CT is given below. Right. Which of the following finding is shown in the CT scan? Ground glass pattern, honeycomb pattern, crazy pavement pattern, then normal scan. Yeah, anyone? Right. So whatever the pattern which is being mentioned here is the ground glass pattern or ground glass opacity. What exactly is ground glass opacity? It's a non-specific pattern actually, where you have the presence of hazy increase in the lung density, right? Where there will be hazy increase in the lung density on high resolution CT scan. That is called ground glass opacities, right? And next is the honeycomb pattern. Where do you have this honeycomb pattern? You will have the appearance of the variously sized cysts. That is called honeycomb pattern. Okay. And this honeycomb pattern is mainly present in case of the interstitial lung disease. In the interstitial lung disease. Okay. Then where do you have this ground glass opacities? That is observed in case of UIP. That is usual interstitial pneumonitis. Right. So, and not only that, even in case of the traction bronchiectasis. Traction bronchiectasis. Okay. Then crazy pavement pattern. Right. Where is that you will have this crazy pavement pattern? Anyone? Crazy pavement pattern is observed in pulmonary alveolar proteinosis. Pulmonary alveolar proteinosis. Right. Now, let me just discuss the various forms of the ILDs. Various forms of the ILDs. Right. Or various etiologies. So first and foremost, exposure to the cement, that will result in asbestosis. Exposure to glass will result in silicosis. And there are some drugs which can cause the ILD, that is amiodarone and methotrexate. Some connective tissue disorders causing ILD, rheumatoid arthritis and as well as scleroderma. Granulomatous conditions causing ILD, sarcoidosis and hypersensitivity pneumonitis. And some unknown causes will be like idiopathic pulmonary fibrosis, cryptogenic organizing pneumonia, acute interstitial pneumonitis, and non-specific interstitial pneumonitis. And usually these patients with interstitial lung disease, they'll have dry cough, not the one with sputum, right? And background history, if you take, right, the bagasosis or the farmer's lung, the individual will be having the history of smoking, or some autoimmune conditions. Okay, and what is that you will notice on the examination? Bibacillar crepitations. Bibacillar crepitations, and there will be clubbing as well. And when you do a pulmonary function test will show you that there is a restrictive pattern, right? There is a restrictive pattern. Only in case of sarcoidosis, because of lymph node, there can be obstructive pattern and as well as restrictive pattern as well in sarcoidosis, right? So imaging has to be done, X-ray, HRCT, and fiber optic bronchoscopy with cryobiopsy, that is considered as the investigation of choice. What is the investigation of choice? That is the fiber optic biopsy, fiber optic bronchoscopy with cryobiopsy, right? And what are the various types of the interstitial lung disease associated with smoking, right? That is DIP, that is desquamative interstitial pneumonitis, right? Then RBILD, then Langerhans cells histiocytosis. Then how do you treat these patients? For idiopathic pulmonary fibrosis, the drugs that we give is pirfenidone and as well as nintedanib. For non-specific interstitial pneumonia, the drugs that we give is prednisolone, mycophenolate, and rituximab. Connective tissue disorders like rheumatoid arthritis, SLE, and scleroderma causing ILD, you need to give steroids. And in advanced stages of interstitial lung disease, the only option for the treatment is lung transplantation, right? Then followed by that, the Hamann-Rich syndrome. So if you take this Hamann-Rich syndrome, what exactly is this? It is an acute interstitial pneumonitis, which will be mimicking the ARDS. And there are some vasculitis which will be causing the ILD, like granulomatosis with polyangiitis, and as well as eosinophilic granulomatosis with polyangiitis. What is that? One is your Wegener's, the other one is Church-Strauss syndrome. Okay, and next is the hypersensitivity pneumonitis is observed in farmer's lung, then the bagasosis, and as well as the byssinosis. So these are the conditions where you'll have the hypersensitivity pneumonitis, right? So this is about the important topics in the respiratory medicine. So I've discussed almost all the topics in the respiratory medicine, which will be important for you from the FMG exam point of view, right? So we are done with the respiratory system as of now, right? So you just take a break. We'll come back and discuss the neurology, okay?
That's how I became a master of AI tools at 40 plus.
Okay, so I'm very sorry for the inconvenience. There is something little emergency which has come up, right? So I'll just wind up this session as of here, right? So the remaining topics I'll take up in the next session. That is neurology, cardiology, then the endocrinology, and as well as the nephrology. I'll be taking that in the next section, right? I'm very sorry for the inconvenience. I'll just wind up this session for now here itself. Okay.